Theories in public health. How do theories from economics and sociology help us design better public health programs? Public health draws on behavioral sciences, including psychology, sociology, and anthropology, to understand and influence health behaviors. In this series, we'll explore three powerful theoretical frameworks that help us design and implement effective public health initiatives. Agency theory examines relationships where one party, the principal, delegates work to another, the agent. In healthcare, this could be a health ministry delegating service delivery to healthcare providers. Innovation diffusion theory explains how new ideas and practices spread through a population. This theory helps us understand why some health interventions are quickly adopted while others face resistance. General Deterrence Theory is based on the idea that the threat of sanctions can deter unwanted behaviors. This theory helps explain why policies like tobacco taxes or fines for violating health regulations can be effective. By integrating these theories, public health practitioners can design evidence-based interventions that address the complex factors influencing population health. In the following sections, we'll explore each theory in detail, examining how they can be applied to design more effective interventions, implement programs strategically, and evaluate outcomes systematically. Information asymmetry is a critical concept in agency theory, especially in healthcare contexts. Information asymmetry occurs when one party in a relationship has more or better information than the other party. In the principal-agent relationship, the agent typically possesses specialized knowledge or expertise that the principal lacks. This creates an imbalance where healthcare providers have significantly more medical knowledge than patients or health administrators. This information gap can potentially lead to misuse of power by healthcare providers. For example, doctors might order unnecessary diagnostic tests, overprescribe medications, or recommend procedures that patients don't actually need. This cartoon illustrates an extreme example of information asymmetry, where a doctor uses their authority to give medically questionable advice. In real clinical settings, information asymmetry is a natural part of the doctor-patient relationship. Doctors have specialized training and knowledge that patients typically don't possess. Information asymmetry is a fundamental concept in healthcare agency relationships. Healthcare providers possess specialized knowledge that patients don't have. This knowledge gap creates an imbalance of power that, without proper oversight, can potentially lead to misuse. Understanding information asymmetry is essential for designing effective healthcare systems that balance provider expertise with patient interests. Moral hazard is a key concept in agency theory that explains the risk when an agent acts in their own self-interest rather than fulfilling their obligations to the principal. In public health, moral hazard occurs when healthcare providers, as agents, prioritize financial gain over patient welfare. For example, ordering unnecessary tests or procedures that increase their revenue but don't improve patient outcomes. This conflict arises because the principal and agent have different interests and goals. The agent possesses more information about their actions than the principal can observe, creating an opportunity for self-interested behavior. To prevent moral hazard, principals implement various oversight mechanisms. These include regular monitoring and auditing of agent activities, measuring performance against predetermined metrics, designing contracts with aligned incentives, and requiring transparency in decision-making processes. A classic example of moral hazard can be seen in executive compensation structures, where healthcare administrators might focus on short-term profits rather than long-term patient outcomes or public health goals. The implications of moral hazard in public health include wasted resources, unnecessary procedures, overtreatment of patients, reduced system efficiency, and ultimately higher healthcare costs for society. Recent developments in agency theory have expanded its application beyond traditional corporate settings. One significant trend is its increased application in public sector governance, particularly in healthcare systems. Modern agency theory now recognizes the complexity of multiple principles, where healthcare providers may answer to various stakeholders simultaneously. The theory has evolved to acknowledge diverse administrative processes across different health organizations. Perhaps most importantly, agency theory has shifted focus from simply monitoring for neglect or malfeasance. The most significant evolution in agency theory represents a fundamental shift in focus. Rather than simply detecting neglect or malfeasance, modern agency theory now emphasizes setting organizational mission and values to align the interests of principals and agents. Stewardship theory offers an alternative perspective to traditional agency theory. Unlike agency theory, which focuses on self-interest and control, stewardship theory assumes that managers act as stewards whose goals align with the organization's objectives. Traditional agency theory emphasizes the conflicts between principals and agents due to differing interests. Stewardship theory, in contrast, suggests that principals and agents can share common goals and interests. The stewardship model is built on two key foundations: trust and shared objectives. Trust is essential in stewardship relationships. Organizations build trust through transparency and consistent behavior. The second key component is shared objectives between principals and stewards. When principals and stewards share common objectives, their interests naturally align, reducing the need for elaborate control mechanisms. Stewardship theory promotes collaborative leadership rather than hierarchical control. Collaborative leadership enables diverse stakeholders to work together toward common goals, fostering innovation and growth. Stewardship theory also influences governance structures, creating more integrated and supportive frameworks. In stewardship-based governance models, stakeholder advisory councils and technical boards work alongside traditional management structures to ensure all voices are heard. To summarize the key differences between agency and stewardship theories, stewardship theory offers a complementary perspective to agency theory, recognizing that organizational relationships can be based on trust and mutual goals rather than just control and self-interest. Pay-for-performance programs are a practical application of agency theory in healthcare settings. Pay-for-performance, or P4P, is a healthcare payment model that rewards providers financially for meeting pre-established targets for healthcare quality and efficiency. This model exemplifies the principal-agent relationship central to agency theory. The principal, typically a health ministry or insurance payer, contracts with an agent, the healthcare provider, to deliver specific health outcomes. Pay-for-performance programs tie reimbursements to specific, measurable healthcare metrics. For example, a primary care clinic might receive additional payments for achieving high vaccination coverage rates in their patient population. The pay-for-performance incentive structure typically includes a base payment plus a performance bonus tied to achieving specific targets. Pay-for-performance programs align with public health outcome frameworks by incentivizing providers to focus on preventive care and population health management. Pay-for-performance programs directly address the challenges highlighted by agency theory. They reduce information asymmetry by requiring data reporting, mitigate moral hazard by shifting focus from volume to outcomes, and align incentives between payers and providers. To summarize, pay-for-performance programs represent a practical application of agency theory in healthcare settings, using financial incentives to align provider behaviors with desired public health outcomes. Provider payment schemes are a practical application of agency theory in healthcare systems. Provider payment schemes are methods used to compensate healthcare providers for their services. These schemes are deliberately designed to influence provider behavior, align incentives, and improve patient outcomes. Healthcare systems use various payment models, ranging from basic fee-for-service to advanced population-based payment approaches. Each model generates different incentives for providers and varying levels of data for policymakers. Traditional fee-for-service models offer limited alignment with quality and health outcomes. Providers are paid per service without incentives to improve quality. In contrast, advanced payment models create accountability by linking payment to quality metrics, cost reduction, and patient outcomes. Well-designed payment schemes generate valuable data for policymaking. This includes clinical data on quality and outcomes, financial data on costs and resource utilization, and utilization data showing service patterns. The Centers for Medicare and Medicaid Services has developed a comprehensive framework for healthcare delivery models. This framework includes both population-based and episode-based payment approaches to align accountability with outcomes. Population-based models focus on overall health management of patient groups, while episode-based models address specific treatment events. Both approaches create accountability structures that align provider incentives with patient outcomes. Data-driven decision-making is crucial for optimizing healthcare delivery. The data generated through provider payment schemes enables administrators and policymakers to make informed decisions about resource allocation, quality improvement, and system design. Modern healthcare systems use sophisticated dashboards to visualize and analyze the data generated through payment schemes. These dashboards enable real-time monitoring of key performance indicators, helping to identify trends, track outcomes, and measure the effectiveness of various interventions. Effective provider payment schemes should follow several key principles. They should align financial incentives with quality outcomes, generate actionable data for continuous improvement, balance accountability between providers and systems, ensure transparency in performance measurement, and adapt payment models to local healthcare contexts. In conclusion, provider payment schemes are powerful tools for addressing agency problems in healthcare by aligning incentives and generating valuable data for policy decisions. When properly designed, these schemes can drive significant improvements in healthcare quality, efficiency, and outcomes. Innovation diffusion theory helps us understand how new ideas and practices spread through a population. This theory provides a framework for analyzing how, why, and at what rate new innovations are adopted by different groups within a social system. The classic representation of innovation diffusion is the S-curve, which shows how adoption typically starts slowly, accelerates as more people adopt, and then plateaus. Innovation diffusion comprises four main elements: the innovation itself, communication channels, time, and the social system where diffusion occurs. The innovation adoption process moves through several stages: knowledge, persuasion, decision, implementation, and confirmation. In public health, understanding innovation diffusion is crucial for successfully implementing interventions and improving population health outcomes. Public health practitioners use innovation diffusion principles across various intervention types, from individual education to policy development and community organization. Innovation diffusion theory is essential for scaling evidence-based practices and achieving widespread public health impact. Rogers' S-curve provides a visual representation of how innovations spread through a population over time. The S-curve shows that adoption starts slowly, accelerates as more people adopt, and then levels off when most potential adopters have embraced the innovation. Everett Rogers identified 5 categories of adopters, each with distinct characteristics and roles in the diffusion process. These 5 groups adopt innovations at different rates and represent different segments of the population. Innovators make up about 2.5% of the population. They are risk-takers who eagerly try new ideas. Early adopters represent 13.5% and are respected opinion leaders who quickly adopt proven innovations. The early majority accounts for 34%. They are deliberate in adoption and follow the lead of early adopters. The late majority, also 34%, are skeptical and adopt primarily due to economic necessity or social pressure. Laggards make up the final 16%. They are traditional and often resistant to change. Each adopter category plays a unique role in the diffusion process of innovations. Innovators introduce new ideas, early adopters legitimize them, the early majority creates critical mass, the late majority follows due to pressure, and laggards adopt only when necessary. Understanding these categories helps organizations develop targeted strategies to accelerate adoption across different groups. Let's examine how innovation diffusion theory applies to the rollout of a mobile app for contact tracing. Contact tracing apps followed the classic adoption curve, with distinct groups adopting the technology at different rates. The rollout strategy targeted innovators and early adopters first, tech-savvy clinics with resources and interest in new technologies. Apps like Everbridge Contact Tracer were initially adopted by forward-thinking health systems with strong IT departments. To reach the early majority, a structured approach was necessary. This included training programs, demonstration projects showing success, technical support, and testimonials from early adopters. Contact tracing apps work by exchanging anonymous codes between phones via Bluetooth. When someone tests positive, others who are in proximity receive alerts. The app creates a traceable zone around each user, monitoring proximity to others while maintaining privacy. This technology needed to be explained clearly to encourage adoption. Several factors from innovation diffusion theory influenced adoption rates. The user-friendly interface design was particularly important in reducing perceived complexity. By following principles of innovation diffusion theory, contact tracing apps moved beyond early adopters to achieve widespread implementation in health systems. General Deterrence Theory is a framework in public health and criminology that examines how sanctions can be used to prevent unwanted behaviors. The theory is built around the concept of deterrence, which involves three main components, as shown in this triangle: certainty of being watched, certainty of punishment, and the choice individuals make when weighing these factors. At its core, deterrence theory operates on a cost-benefit analysis. People decide whether to engage in behaviors by weighing potential consequences against benefits. Effective sanctions increase the perceived cost of undesirable behaviors. In public health, general deterrence theory is applied through three key elements. Certainty refers to how likely non-compliance will be detected. Severity represents the magnitude of the penalty. And swiftness indicates how quickly the penalty is applied after detection. Public health systems use deterrence-based approaches for issues like tobacco control, infectious disease prevention, and promoting healthy behaviors. A country's health spending influences its capacity to implement such measures. Examples of deterrence in public health include fines for non-compliance with smoking bans, penalties for violating quarantine orders, and taxes on products like tobacco and sugar-sweetened beverages. General deterrence theory relies on three key elements that work together to influence behavior through the threat of sanctions. The first key element is certainty. This refers to the likelihood of getting caught and facing consequences for a behavior. When people believe they are likely to be caught, they are less likely to engage in prohibited behaviors. The second element is severity, which is the harshness of the punishment or consequences. More severe penalties are theorized to have a stronger deterrent effect, though research shows this relationship is complex. The third element is swiftness, which refers to how quickly the punishment is applied after the violation. Immediate consequences have a stronger deterrent effect than delayed ones. These three elements interact to determine the overall deterrent effect. Research suggests certainty of punishment typically has the strongest effect, while severity and swiftness enhance the deterrent impact. For example, traffic enforcement combines certain detection through cameras and police presence, moderate fines as punishment, and immediate ticketing to create an effective deterrent system. The most effective deterrent strategies strike a balance between all three elements, though the optimal mix depends on the specific behavior and context being addressed. General deterrence theory has seen several important developments in recent years. A major recent trend is the application of deterrence principles to encourage compliance with COVID-19 preventive measures. For example, many jurisdictions implemented face mask mandates with fines for non-compliance, using formal sanctions to deter risky behavior. Another key trend is the growing recognition of the role that informal sanctions play alongside formal penalties. Researchers now recognize that social disapproval and community pressure can sometimes be more effective than legal sanctions. Social conformity has become a powerful deterrent as people often comply with health guidelines due to fear of social judgment and desire for approval. As seen during the pandemic, the social pressure to wear masks in public spaces often reinforced formal requirements. Recent trends in general deterrence theory include the integration of formal and informal sanctions, a focus on community norms and social pressure, and rapid policy implementation during public health emergencies. In general deterrence theory, understanding individual and social factors is crucial for effective interventions. Individual factors like self-efficacy and risk perception strongly influence how people respond to deterrence measures. Risk perception is especially important as it's influenced by personal experiences, cognitive biases, availability heuristics, and media influence. Social factors including norms, peer influence, and cultural context also play a significant role in determining compliance. These individual and social factors influence how people perceive problems, evaluate information, and make decisions about compliance. Numerous barriers can prevent compliance with public health measures, including knowledge gaps, limited resources, competing priorities, and psychological resistance. To be effective, deterrence efforts must use tailored interventions that address specific barriers to compliance. In summary, effective deterrence strategies must consider both individual factors like self-efficacy and risk perception, and social factors like norms and cultural context. By addressing specific barriers with tailored interventions, public health officials can significantly improve compliance. COVID-19 preventive measures provide an important application of general deterrence theory in public health. General deterrence theory suggests that the threat of sanctions can deter unwanted behaviors. During the pandemic, both formal state-enforced controls and informal social controls were used to encourage compliance. Formal controls included legal mandates, fines for non-compliance, and enforced business closures. Informal controls included social disapproval, peer pressure, and evolving community norms around protective behaviors. What made COVID-19 prevention unique was the intertwining of these formal and informal control mechanisms. Social control mechanisms reinforced state directives with community norms and official guidance working together. This combination approach was applied to various preventive measures, including mask wearing, social distancing, and vaccination. Vaccination efforts particularly demonstrated this dual approach, with formal requirements supplemented by social encouragement to protect vulnerable community members. The COVID-19 response showed that general deterrence is most effective when formal sanctions and informal social controls work in tandem. In general deterrence theory, the perception of risk plays a more significant role than the actual punishment itself. While punishments exist objectively, it's how individuals perceive these risks that ultimately influences their behavior. When individuals perceive a higher risk of consequences, they are more likely to avoid certain behaviors, regardless of the actual likelihood of punishment. Public health campaigns leverage this principle by effectively communicating risks to promote behavior change. For example, this billboard emphasizes how a pregnant woman's choices directly affect her baby. Effective risk communication goes beyond simply providing information. It involves engaging the public in meaningful discussion and recognizing their role in decision-making. To effectively communicate risks, public health campaigns should use clear language, present balanced information, personalize messages, offer concrete actions, and address emotional responses. When risk perception is effectively shaped, it can motivate both individual behavior change and collective action, as demonstrated by social movements responding to public health threats. To summarize, in public health, risk perception is a powerful tool for behavior change. Effective campaigns don't just inform, they shape how people perceive risks and empower them to take action. In the context of deterrence theory, sanctions can be categorized as either formal or informal. Formal sanctions are official punishments imposed by authorities like fines, imprisonment, or other legal penalties. Informal sanctions, on the other hand, involve unofficial social penalties like disapproval, exclusion, or shame. When comparing these two types of sanctions, we can see some key differences in how they function and their effectiveness. Research consistently shows that informal sanctions often have a greater deterrent effect than formal legal sanctions. Peer pressure is a powerful example of an informal sanction. The fear of rejection, desire for social acceptance, and concerns about one's reputation can strongly influence behavior. Social stigma is another powerful informal sanction. Being pointed at or singled out creates emotional and practical consequences that formal sanctions often cannot match. Social norms are the unwritten rules that guide behavior in groups and societies. They create expectations about appropriate behavior that guide how we act. Fostering a culture of social responsibility can amplify the power of informal sanctions. This involves promoting community involvement, highlighting positive role models, and encouraging peer-to-peer accountability. By strategically combining formal and informal sanctions, public health initiatives can achieve greater compliance and more sustainable behavior change. In this final section, we'll explore how integrating agency theory, diffusion theory, and general deterrence theory can create powerful tools for public health interventions. Agency theory helps align incentives between health systems and providers, ensuring efficient service delivery by addressing information asymmetry and moral hazard. Diffusion theory provides insights into how new health interventions spread through populations, identifying adopter categories and factors that influence adoption rates. General deterrence theory leverages the certainty, severity, and swiftness of sanctions to promote healthy behaviors and discourage harmful ones. By integrating these three theories, public health leaders can design more effective evidence-based interventions. This approach connects policy design, implementation strategies, and enforcement mechanisms. Combining these theories allows public health leaders to design payment systems that align provider incentives with public health goals, strategically target different adopter categories when implementing new health interventions, balance formal sanctions with social norms to enhance policy compliance, and consider social context when designing incentives and communication strategies. In conclusion, by integrating agency theory, diffusion, and general deterrence, public health leaders can design smarter programs, spread proven innovations, and enforce behaviors that ultimately save lives.